Bismillah ar-Rahman ar-Rahim. It gives me a great pleasure to be here with you this evening. I will talking about one of the some considerations for the treatment of the cataract in the eyes with glaucoma. Several facts that the cataract and the glaucoma happen together, happen in old ages, and more frequently the patient who has glaucoma has cataract as well. First, we have to be sure that there is a glaucoma. Glaucoma is not an IOP problem. All of us check an IOP, but we have to do a visual field and also OCT, and we have to look for the details in the fundus. Maybe there is a branch in the routine cataract, branch retinal vein occlusion with severe glaucoma. We have to do gonioscopy particularly if I want to use mixed procedures. There is we have to take care of some consideration. Glaucoma patients want to see well, so we have to maximize refractive correction, correct astigmatism. Glaucoma patient benefit from the toric as well as much as any patient. PICs may be at risk. And we have to avoid the multifocal IOL because it's maybe impaired the visual field detection. Monovision is required, and maybe enhanced monovisual, it's okay. Glaucoma patients want to stop their drop. Several studies show the value of the cataract surgery in getting the pressure down, but there is some caveats. It's an incremental improvement, not cure, and a good chance to stop the drops. Many patients refer to me with 3 drops, and these drops not doing anything. So we have to stop it and see what's really working. IOP reduction is greatest in the patient with ocular hypertension, early glaucoma, and narrow to close glaucoma. And the science is by maybe it's curative, and by due to widening the angle, sharing with the lens vault. Gonioscopy and anterior segment OCT show the angle morphology of the iris and the lens vault, but it's not very effective in chronic angle closure glaucoma. There is a variety of the minimal invasive glaucoma surgery that provide additional degree of lowering the pressure when combined with phacoemulsification like iStent, Xane, Cahook, and it's now get a big attention. But the question is this PIT benefit from lowering the IOP? The question is worth the higher cost? So large randomized trial are needed. Our option, cataract alone or trabeculectomy alone or combined. Trabeculectomy alone probably has a higher success rate than combined procedures. Sometimes if we have significant cataract and you have to go back and get it out, the subsequent surgery may cause a slow in the work of the PIP, and maybe even it failed. So for the cataract surgery with trabeculectomy, I do it rarely, but if there is a significant cataract, usually if the pressure is very high, for the eyes in which marked degree of IOP lowering is required, with eyes on multiple medications, poor IOP control, severe glaucoma damage, and need for a very low IOP. Cataract surgery also combined with tube shunt for the eyes with multi-field surgery before. We have to avoid complication. Glaucoma patients are more likely to have small pupil. Pure visualization results in capsule tears. The key is don't be a hero. Managing the pupil by pharmacology tools like epinephrine or by devices and managing the medication to avoid CME. We have to expect the IOP rise post-operatively. Several ways to manage intraoperatively by Myotic, by using Diamox prophylactic as a prophylactic, and steroid-induced glaucoma, it needs approximately 2 to 4 weeks to rise the IOP. So at the first or 2 days, maybe there's another reason like viscoelastic. And it's a good chance to clear the slate and to arrange the medication again. To conclude, we have to be sure that there is a glaucoma. Check visual field and posterior segment. And a glaucoma patient want to see well and he deserve. And glaucoma patient want to off or stop their drops. And be careful, glaucoma patient at a high risk of high risk category. We have to expect and to manage post-operative IOP rise. And thank you.